Well, thank you for joining us. We're going to launch the 2025-26 academic year epilepsy grand rounds at university hospitals. My name is Neel Fotedar. I'm the director of epilepsy grand rounds. I'm going to kickstart this year's sessions, and I can promise you that the quality of speakers is only going to get better and better. I would also like to congratulate our fellows and any of the other fellows. Any other fellows who might be watching remotely, congratulations to you as well. Since we're in the first quarter of the year, we're still early in fellowship. I figured we would discuss a topic which is very important to understand epilepsy and the principles of epilepsy surgery, which is the epileptogenic zone. So hopefully, through this session, we'll have a more refined understanding of what it is and what it stands for. Let's just make sure I'm on. Yep, perfect. Okay. For people on Zoom, this is a webinar format. If you have a question, you can put it in the chat towards the end of the session. If somebody has a question, we may be able to unmute you, but you won't be able to unmute yourself in the middle. Okay, let's get started. Okay, I have no relevant disclosures. I do have an R21 grant as a co-PI, it's not relevant. So our objectives today, we're going to review the cortical zone theory of epilepsy and its relevance to epilepsy surgery. We're going to discuss the evolution of the concept of epileptogenic zone, and we're going to discuss the similarities and differences in the Luder's theory of the epileptogenic zone and the Van Gogh theory of the epileptogenic zone. So what is exactly the cortical zone theory, and why are there so many zones in the first place? So this is my, play on the words, so-called network of zones. So we all know we love the word network here. As you guys are familiar with already, there are several zones postulated in the cortical zone theory of epilepsy. You have the irritative zone, the seizure onset zone, the spread zone, the symptomatogenic zone, the epileptic lesion zone, the functional deficit zone, and then the most important one, which everybody's after, which is the epileptogenic zone. And there's a schematic up here, which you can see, which we'll go into again later, as this is a hypothetical schematic to show the spatial relationships of these areas of the brain. What is the definition? So there's two fundamental definitions. There's a North American one proposed by Luders and colleagues starting in 1993, 2001, and 2006. And then there's a French definition, which was originally proposed in 1966 by Taliac and Van Gogh. So the North American definition is the epileptogenic zone refers to the minimum area of cortex, which is necessary and sufficient for initiating seizures, and whose removal or disconnection is necessary for complete abolition of seizures. To keep it simple, this is the minimum amount of cortex that must be resected, inactivated, or completely disconnected to produce seizure freedom. This is a hypothetical concept in the sense it cannot be defined by any testing modality, not even intracranial EEG. This is very important to understand. We can estimate it, but we cannot define it or fully delineate it up front. And we'll get into it. We'll show you a couple of examples of how this applies. Then there's a French concept, which was proposed by Jean Taliac and Van Gogh in 1966, which is similar, but there's some important differences. They define the epileptogenic zone as a site of the beginning of the seizures and of their primary organization. It's important to remember that this is an SEEG-based definition. It's a stereo EEG-based definition, which was obviously, first used extensively by Taliac and Van Gogh in France, and that's when they came up with this definition. Now, this does not mean that this concept did not exist before. So in the entire pre-EEG era, before EEG became popular, the first person who championed this concept was obviously Sir John Hewlett Jackson. He was the first one who recognized epilepsy as a disorder of the brain, in the sense that it's a disorder of the gray matter. And he was the first one to say that there's an area of gray matter which is discharging in an abnormal manner. And so in today's words, they defined epileptogenic zone simply by what is called the symptomatogenic zone, because they did not have any testing modalities. There was no imaging, there was no EEG. It was purely clinical observation going by the symptoms that the patient was having, starting with the first one, the second, and the third. So this was championed by Sir John Billings Jackson and his surgeon, Victor Horsley. They performed several surgeries. Mostly they were small resections of the areas of the cortex, which they thought were responsible for producing the symptoms. In some cases, they were successful, but in some cases, they were not successful, as you would understand today. But you have to imagine back then, they were doing this with no testing by simple clinical observation. So the seizure focus was defined by the first symptom of the seizure and the area of the brain that would have to be activated or disrupted by the seizure discharge. However, going back to the schematic, which we'll go into more detail, you know that the symptomatogenic zone may or may not overlap with the epileptogenic zone. It may be at quite a distance from the epileptogenic. So just because a first symptom occurs does not mean the seizure also started there, whatever is the first observable symptom. So which is why they were probably not very successful at getting many patients cured for epilepsy, but this was the beginning. Now we'll take a brief detour. This is my favorite thing to teach the fellows. I call this a flat brain model, okay? Think about the brain in two dimensions, X and Y, okay? The Z here is a time. So this area, this red dot over here, you can see my cursor, right? Yeah. Imagine that is the site of the beginning of the seizure. That's where the seizure is starting, all right? So as we go forward in time, you will see as how the seizure evolves and how symptoms emerge. So let's assume for a second, at time T1, the seizure has invaded a certain amount of territory, okay? Does that mean you're going to have a symptom? Not necessarily, it depends where it is, right? You may have a symptom which may be produced by an activation of an area of cortex called X. It may not be the entire area that the seizure is invaded, it may be a small area. Then as a seizure continues to evolve, you may now activate a second area, which may lead to a second symptom to emerge, and then so on and so forth, okay? So this evolution, the spatial temporal evolution of the seizure discharge at the brain leads to the classic temporal evolution of the seizure symptoms as a seizure evolves. So when you do semiology classification and you write symptom A to B to C with the arrows are not just arrows, they're arrows of time. They're marking the temporal evolution of the signs and symptoms as a seizure moves forward. And what you are doing when you're looking at the semiology and you're analyzing it carefully, you're basically retracing your steps from C to B to A and trying to identify the corresponding areas, Z, Y, and X, what those might be. And what you're trying to get to is the first one because that's probably the closest. So why is the temporal analysis so important? As I mentioned, the expression of the ictal semiology is a direct function of the spatial temporal evolution of the seizure discharge in the brain. When you do a very careful analysis of these signs and symptoms, it does help you localize the corresponding symptomatogenic zones, okay? The first symptom and its further evolution provides invaluable information. So the first symptom is very important, but also the evolution is also very important. Both are very important. And I'll show you an example of why that's the case. Not all the symptoms are helpful. Some symptoms do not have very high localizing value, as you guys have learned so far. And however, that does not mean you don't include it. The more focal a symptom, the more likely it is to be localized to a smaller area of the cortex. Hence, it is very likely that that area is very close to the seizure onset zone. Because as the seizures spread and invade, they usually invade larger and larger territories of cortex. So, which is what makes auras very important, because auras are usually produced by activation of a very small area of the brain. Hence, the seizure onset zone is usually very closer, okay? And as Dr. Luders always says, the most important symptom of a seizure is the first symptom, okay? You analyze a semiology and you write it in temporal evolution, right? Automotor to left versive to bilateral tonic-clonic seizure. And you list his lateralizing signs. You have the left facial grimacing, right figure of 4 ictal and right clonic. Overall, the semiology strongly points that the epilepsy is focal and it is in the right hemisphere. The only sign that disagrees with that is a right figure of 4, but out of all the other signs, it's a relatively poor, it has relatively lower positive predictive value, and the others are very powerful, and there's an overwhelming majority indicating that the seizure, that the epilepsy is in the right hemisphere. Now, however, none of these are localizing in that sense, and that they don't tell you where in the right hemisphere necessarily. Now, if you just go by statistics, you're saying it's temporal lobe epilepsy, and as I mentioned before, most common epileptogenic zone associated with autoelementary automatisms is temporal lobe. So you'd be correct in saying this is most likely right temporal lobe epilepsy. And then there are some other, more nuanced analyses like the time it takes for the version to develop from the onset of automatisms, which tells you most likely is an extrafrontal epilepsy as well. Now I'm going to give you two hypothetical scenarios in terms of what his aura is, and that'll hopefully I can get you to understand how big of a difference will that make in the story. This is the first hypothetical scenario. He gets a feeling of rising hot sensation in his belly associated with the smell of burning motor oil. After that, he doesn't remember anything. And the second scenario, they're both hypothetical. He says, oh, doc, I see fleeting images of red and blue circles and triangles out of my left eye. After that, my vision is shaky, and then I don't remember what happened. So these are two hypothetical scenarios where the auras are different, and you can understand how big of a difference will that make. So in the first one, the aura, as you guys know, would be the abdominal aura and the olfactory aura. And as you guys know, the symptomatogenic zone of abdominal aura is posterior insula, right? And the symptomatogenic zone of olfactory aura is likely amygdala or piriform cortex, or what is called the periamygdaloid cortex. For the visual aura, the symptomatogenic zone would be, because he says left eye, usually when patients say left eye, they usually mean the left field. They don't usually mean left eye. That would be the right pericalcarine cortex, right? In area B1 or Brodmann area, because of the way he's describing, it's a very simple visual aura, simple shapes, simple triangles and colors, and shaky vision usually occurs because of a little bit of nystagmus they might get with it. So these are two hypothetical scenarios, and I'm going to show you how that would make a difference. Let's look at this anatomy diagram. Let's look at how scenario one would play out. So let's say here, the first symptom was the abdominal aura, or the epigastric aura. The symptomatogenic zone would be the insula, most likely. It is the insula, most likely. So does that mean that the seizure also started in the insula? Of course, it's possible. However, as we know, insular epilepsy is exceedingly rare as compared to temporal lobe epilepsy. And in majority of cases with an abdominal aura, the seizure almost always starts in the mesial temporal lobe, and then it spreads into the insula, and that's what produces the abdominal aura. So the onset in the mesial temporal structures, whether the hippocampus or amygdala, better explains the auras, both the abdominal and the olfactory, with the spread in the periamygdaloid. And then the seizure inactivates bilateral language areas, bilateral hippocampi, and that's what produces the dialepsis, which, because he doesn't remember anything afterward, and he's dialeptic during the phase of the automatisms. And the automatisms, we don't know the exact mechanism, but perhaps a disinhibition of a central pattern generator in the brainstem responsible for chewing and swallowing that can produce that. And he gets aversion by activation of the frontal eye field in the ipsilateral hemisphere. And while that happens, the seizure is also spreading in the whole brain, in the same hemisphere and across. And that's what gives rise to the bilateral tonic-clonic seizure. So this is more or less what scenario one would look like if that was his aura. In scenario two, the aura is very different. He has a visual aura in the left hemifield. So that must start in the right pericalcarine cortex. That means the seizure is probably starting very close to that, which happens. And usually when occipital lobe epilepsies occur, which are also quite less common, they start in the occipital lobe, and that produces the visual aura, and then they very rapidly spread in the temporal lobe. And the rest of the semiology may essentially mimic a temporal lobe epilepsy, and it may look exactly similar to scenario one. However, the aura makes a dramatic difference where your epileptogenic zone might be in this case. No matter what your other testing parameters say, you cannot ignore the value of the aura in this particular case. So the first symptom is important, and the evolution is also very important. So after 1935, when EEG became more popular, you have to understand, Penfield did most of his initial cortical stimulation work with Baldry without Jasper, without EEG, just doing stimulation without monitoring for after discharges. The original papers were written around early 1935. It's only after Jasper joined Montreal that they started using EEG. So after 1935, in the post-EEG era, then we have defined two areas, which is the irritative zone, which is the area of the cortex that generates interictal epileptiform discharges. You can define it either by scalp EEG or intracranial EEG or MEG. Seizure onset zone is the area of the cortex from which the seizure is generated, which as measured by scalp or intracranial EEG. You can also measure it by ictal SPECT. It's important to remember that the irritative zone is usually quite large compared to the actual epileptogenic zone in most cases. It's important to remember, especially for people who do intracranial EEG and epilepsy surgery, is that none of these zones individually equal the epileptogenic zone. Seizure onset zone is not equal to epileptogenic zone. The irritative zone is not equal to epileptogenic zone. None of these individually are equal to the epileptogenic. Neither is the seizure onset zone, even when defined by intracranial EEG. It is not equal to epileptogenic zone. It's very important to remember that, an error that sometimes we make. What is very interesting is the hypothetical spatial relationship between the seizure onset zone and the epileptogenic zone, as defined by any modality. So I have 4 hypothetical scenarios here. With scenario in the upper left corner, these are all seizure onset zones as we have defined by whatever modality is available to us. And let's say in the first one, the epileptogenic zone perfectly overlaps the seizure onset zone. So in this case, if you remove the entire seizure onset zone, you might have a very good outcome because you got rid of the whole thing. In the second scenario, the epileptogenic zone is actually smaller. It's a smaller subsection of the seizure onset zone as you have defined. Again, if you remove the entire seizure onset zone, you're very likely to be quite successful. The bottom 2 are the problem. So here's one where the epileptogenic zone only partially overlaps with the seizure onset zone that you have defined. Here, if you only resect the seizure onset zone, we're going to have a problem. And the second one, the overlap is even less. Okay. So in these 2 scenarios, there is this one area of the brain that we are not able to define by all the modalities that are available to us. And this is what Dr. Luders called the potential seizure onset zone. This is from the Epilepsy Colloquium in Munich in 2002. And if you read what he has written on the back, it says electroencephalography can only measure the actual seizure onset zone. The epileptogenic zone, which includes the potential seizure onset zone, cannot be measured directly, does not have a biomarker as far as Luders' theory is concerned, which is why you cannot define it completely up front. That is the reason sometimes people have a hard time understanding that. So if we come back to the case here, out of these 2 hypothetical scenarios, the real story is the first one. This is his aura. He gets a rising hot sensation in his belly, followed by burning motor oil. So the scenario 1 is the correct scenario. So then you modify your semiology classification. You write the aura, which is the first thing that happens, abdominal or / olfactory, both. And then the rest of the semiology we had already written down. You write multiple lateralizing signs. The ones in red strongly point to the right hemisphere. And the abdominal aura followed by oroelementary automatisms very, very strongly points to the epilepsy in the mesial temporal structures. It has a very, very high positive predictive value. So now you can very confidently say, without looking at any testing so far, that this person most likely has a right temporal lobe epilepsy. You can be even more confident, you say most likely has a right mesial temporal lobe epilepsy. What you don't know is the etiology, what has caused it, and what are the related medical conditions. So then you go into other testing. This is how other testing modalities complement your semiology analysis. This is his interictal EEG. As you can see, it's a very, very clear spike in the right temporal region, maximum at SP2, kind of isopotential at SP2 and F8. This is the isopotential map. This is his seizure. That's where he gets the arousal. Then you can start seeing this blunt-shaped rhythmical activity appearing in the temporal derivation again. Also maximum SP2 FD10. Then you have the other 2 zones, which is the epileptic lesion zone, which is where the lesion is, which is obviously in majority of cases defined by a high resolution MRI. You can also define it by EEG by looking at focal slowing, continuous focal slowing on an EEG. Then you have the functional deficit zone, which is defined by the neurological deficits on exam that the patient may have on their neuropsychological evaluation. EEG and the FDG PET is usually what we use. So as you know, the advances in MRI have really helped us define several lesions that were not defined before. So it has really helped significantly. This is this patient's MRI. You can see he has a subtle, not subtle, he's a relatively obvious flare hyperintensity in the right hippocampus, as we have suggested for now. You modify your classification further and you enter the etiology as mesial temporal sclerosis, okay? And he has his other conditions. So what is the relationship between all these zones? So you have the epileptic lesion zone, then you usually have the area of the brain where the seizure starts and usually spreads into a certain territory, which is usually the early spread zone. And then you have the various symptomatogenic zones producing the certain various symptoms of the seizure, which may or may not overlap with these areas. What your hope is that all of this stuff is in the non-eloquent cortex. So if you have to resect it, you can resect it safely. Of course, that doesn't always happen. It may overlap with the eloquent cortex. And then you have this. This is the troubling part, the potential ictal onset or potential seizure onset, which cannot be defined clearly. And the putative epileptogenic zone, and hopefully your resection margins are going to encircle at least all of the seizure onset zone, the lesion, and what the potential one might be. This is the hard part that is difficult to define, which you get better at as you get more experience in epilepsy surgery. So when you do your phase 1 evaluation, all of these pieces of data are important. One is not more important than the other. One may become more important than the other depending upon the quality of data that you've collected. So your semiology gives you invaluable information as to what are the different symptomatogenic zones that are involved. Your scalp EEG gives you the irritative zone, the seizure onset zone. The MEG usually gives irritative zone, usually can't do MEG long enough to record a seizure unless it just happens to happen there. Equital SPECT is another modality which you can use to define the seizure onset zone. You have high quality MRI for defining your lesion. You have the PET for functional deficit zone. If you do a case and all of these areas point to relatively localized area of the cortex being the problem, then in majority of cases, you can go straight to resective surgery and very likely your outcome is going to be good because this is most likely the epileptogenic zone if all of them are pointing to the same area. Now, that does not mean you don't have to do SEEG or grids here. You may have to do it, especially, for example, let's say it overlaps eloquent cortex and you want to define it clearly. You can do a phase 2 and then do the resection depending upon what you find, and then hopefully you still have a good outcome. The problem is when all of them point to slightly different areas. So you have what is discordance amongst the various pieces of data that you have. Now, in these cases, often phase 2 is very invaluable because it may solve the problem for you. You do the phase 2 evaluation and you hope that it solves the problem and then finally puts it together into one area, and then you go to resective surgery anyway and hopefully have a good outcome. But this does not mean that phase 2 will solve the problem, okay? Especially if you did a very good job at doing a good phase 1 evaluation, and if you really have truly discordant data, it probably means the patient does not have focal epilepsy, focal at least in the sense that it can be resected safely that way. So, however, I'll show you cases, 2 examples where hopefully this approach will be reflected. Then you have the recently more popularized, what is called the network theory. If you do a PubMed search, you can see how the publications referring to the term epileptic networks has exponentially risen in the last few years. So it has been used by the French since the very beginning, but it was kind of, brought to attention here in the United States in this paper by Susan Spencer, published in Epilepsy in 2002. And she defined as, I consider a network to be a functionally and anatomically connected, bilaterally represented set of cortical and subcortical brain structures and regions in which activity, one part affects activity in all others. Makes sense. Brain is the brain doesn't work in isolation. Different areas are connected to each other. The essential operational component of this definition is the observation that vulnerability to seizure activity in any one part of the network is influenced by activity everywhere else in the network. And that network as a whole is responsible for clinical and electrographic phenomena that we associate with human seizures. So you can see how this, you could, if you have to think about it in terms of zones, how they may be referring to different zones being connected to each other. Now, this is the one where I don't necessarily agree. Implicit in this idea is that seizures may entrain this large neural network from any given part such that it becomes irrelevant to discuss the onset of the seizures in any specific part of the network. In other words, electrical hyperexcitability associated with seizure activity reverberates within the neural structures which operate together and inextricably to culminate in the eventual expression of seizures. Important corollaries that derive from these ideas are the interruption of the network and a structural sense or modification by electrical, biochemical, or metabolic influences in any part will alter seizure expression. So this is probably the basis of all neuromodulation these days. The idea is no matter where the seizure starts, if you interrupt the network somewhere, we know that doesn't work as well because the onset is still more important than the rest of the network of the zones, okay? So if you look at, this schematic without the labels that I showed you with all the zones, it's, of course you can think, oh, well, these are interconnected. So this is a network. So if you spread them out, they look like interconnected areas of the brain. Of course, a seizure is propagating along a certain pathway. So you can kind of see the network hidden inside the zone, huh? Just don't tell Dr. Luders we said that, okay? So the question then becomes, is the resection of the focus or the zone the same as modulating the so-called network at any nodes? I don't necessarily think that's the case. I think, there is no comparison in terms of seizure outcomes for resective surgery versus any other modality. So a well-defined, well-done resective surgery where you remove the epileptogenic zone carefully is far superior to anything else you can do. So, if you guys look at that landmark trial published in New England Journal of Medicine, the first one, double-blinded for temporal lobectomy for temporal lobe epilepsy. If you look at the number needed to treat in that study to produce a significant reduction in seizures after surgery, what do you think the number needed to treat was in that study? Two to treat. It's 2. The number needed to treat is 2, which is incredible. I've never seen such a low number needed. So you have to treat 2 patients with temporal lobectomy and temporal lobe to make a remarkable difference, which is extraordinary in terms of medical treatments. So the epileptogenic, so now the term that is now used is called epileptogenic networks or epileptogenic. So and there are several inside it. So this is a review published in 2024 by Professor Bartolome. And if you look at this picture here, the red dots point to the epileptogenic zone network, which are these different nodes of the brain connected, which constitute together the epileptogenic zone, which I think means that all of these areas, this is where the seizure starts and organizes before it spreads everywhere else. These ones in blue they call it the propagation zone, which could be the early spread, or the spread zone, which is where the seizure spreads into and may produce a symptom. So it could be a constellation of different symptomatogenic zones. And then you have these areas which don't get involved in the seizure. Different groups have proposed different biomarkers to define the epileptogenic zone. For example, the one that Professor Bartolome's group has defined as what is called epileptogenicity index, which is a function of how much fast activity a certain area of the brain is able to generate in a seizure and how delayed is its involvement. This can only be defined by SEEG. Okay, maybe there's a way to define it on scale, but mainly it's defined by SEEG. And they propose that epileptogenic zone network has the epileptogenicity index of more than 0.4. And there are, like software is a variable which you can run through your SEEG and which you can calculate, but I would caution you on just using this to define what the epileptogenic zone is, okay? But that is one way. So if you look at these 3 hypothetical scenarios in this paper, the first one here, if you see up here, A, the lesion and the epileptogenic zone are quite close to each other. So this is a very focal epilepsy. Then you have this area where the lesion is small, but the epileptogenic zone is a little more widespread. And then you have this unusual scenario where the lesion and the epileptogenic zone are quite separated. So this obviously is a very focal epilepsy. Here, the focus or the epileptogenic zone is larger, depending on this. Usually, in many cases, it ends up being a function of what is the cause of the epilepsy, or what is the underlying etiology. For example, if you go back to the previous picture here, in terms of what is the intrinsic epileptogenicity of the lesion. So, for example, a focal cortical dysplasia, these are highly intrinsically epileptogenic lesions. The seizure starts within the FCD itself. So here, you may not have to do an SEEG. If you resect it, you may have a very good outcome. Then you come to other problems, for example, post-stroke epilepsy, where the stroke may be large, the area of damage is quite large, and obviously the lesion itself is encephalomalacia, the gliotic scar may be very large. So there may be a very large area that may be epileptogenic. So in that case, that would be like scenario number C here, where the lesion and the epileptogenic zone are separated and the epileptogenic zone may be quite large, and you may need to do SEEG to delineate it very well, unless you can go straight to a very large resection, which you can't. I'm going to skip this one. So in terms of usage around the world, was a study, very nice study published in 2024 by Dr. Frauscher's lab, where they investigated the trends of use of terms related to SEEG around the world by epileptologists working in level 4 epilepsy centers with access to SEEG. So they had a total of 321 experts from 39 countries. And the majority of experts favored the Luder's epileptogenic zone definition, which is 68.5%. What was a little interesting to me was that was predominantly in Europe. In the United States, the Banco definition is a little more popular. That may have to do with the recent popularity of SEEG in the United States. It's a little more popular, but it's still overwhelmingly in North America, the Luder's definition is still very popular, in Europe as well. But why is this more widely acceptable? Well, it's very pragmatic, it's very practical, it's very well described, and it's very well defined. Each zone is very well defined. It works quite well for surgical planning because of its clear definitions. And the other reason for that is the SEEG-based definition primarily remained restricted to France and Italy and some other parts of Europe. before SEG gained popularity in the rest of the world, and particularly in North America. As you know, SEG was introduced in North America when Professor Luders went to France and took his team there from the Cleveland Clinic to learn, and then brought it over. And they sent one of their very young surgeons, Dr. Martinez, to learn the technique of SEG. It was introduced first in Cleveland in the United States. However, prior to that, large centers like the Cleveland Clinic and Montreal had been using grids as ECOG to do epilepsy surgery for many years and were quite successful because of their meticulous planning for phase one. So I'll show you two cases to highlight how you may or may not need phase two. So let's look at this one. It's a 23-year-old right-handed woman. Seizures started at the age of 15. She recalls her symptoms. She has a feeling that she's unable to breathe. After that, she's aware of being unable to move her body. She's not aware of what happens after that. The witness described, mom describes, she has whole body shaking followed by confusion. So she has an aura. I don't know really how to define her aura, but the inability to move her whole body could be an akinetic seizure, whole body akinetic seizure, and then seems like it may be followed by a bilateral tonic-clonic, or by at least a bilateral clonic seizure based on the report provided by the mother. So if you just think about this, just by the semiology, it's hard to lateralize it because you have no lateralizing signs that report it, so you don't know which hemisphere, but you may be able to localize. Akinetic seizures in isolation are not very common. And the symptomatogenic zone is probably one of the negative motor areas, and both of them are in the frontal lobe. It could be a frontal lobe epilepsy. You don't know whether it's left or right. So you gather more information. This is her scalp EEG. There's a very subtle continuous slowing in the right frontal lobe in a run 5, as you can see right there. And she had spikes mainly localized to the right frontal as well, maximum at F2, and then F4 and FZ. There's isopotential map right there. And then we recorded the seizure. The seizure onset, as you can see marked here, was also in the right frontal region. This is the isopotential map, FZ and F2, very mesial right frontal. And then it was started by hyperventilation and tachycardia, which is what she said is the inability to breathe, was actually hyperventilation. So I don't know if that's a response to fear or that's a primary symptom because she's also scared. Then she reaches for the button and she stops moving 25 seconds later after the seizure has started. So she has the aura, then she has the whole body akinetic, and then it actually evolved into a left face clonic, by which time she was completely dialeptic and had a bilateral tonic-clonic seizure. So this is the evolution of her semiology. She did have other lateralizing left versive during the evolution to the second convulsion, and she also had a left arm tarsi paresis after the seizure had ended. So now you have several very strong lateralizing signs pointing to the right hemisphere, and you have good quality scalp EEG data also pointing to the right hemisphere. So most likely you have a right frontal lobe epilepsy. On her MRI here, you have this relatively anterior coronal cut on the T2 and a sagittal T1, and I've highlighted the relevant structures. And if you draw your attention up here, you can see there is significant blurring of the gray and white junction in the right superior frontal gyrus, particularly the mesial aspect. And we tracked it forward. It was on several cuts before it disappeared. So we approximated that this was the approximate AP extent of this cortical dysplasia. It's overextended a little bit. So this is primarily in the mesial part of the superior frontal gyrus, quite anterior to the SSMA, and probably close to the pre-SSMA. So you can see how this would produce an akinetic seizure without loss of consciousness in this particular case. But it stayed above the cingulate sulcus. So in this case, the symptomatogenic zone for the akinetic could be the supplementary negative motor area rather than the primary negative. So that is well defined. Irritative zone is right mesial frontal. Seizure onset zone is right mesial frontal. Epileptic lesion zone is right mesial frontal. She did not, her PET scan was negative. She had no deficits in exam. Her neuropsych was okay as well. So the functional deficit zone is not defined. However, all of the data point to one area. So this is a case where the data are very concordant. So most likely your epileptogenic zone is right mesial frontal. So we went straight to surgery. In this case, so the epileptogenic zone is defined as an approximation of the other zones. In this case, because the data are concordant, we had high confidence that we are in the right area of the brain. So we went straight to lesionectomy. We did use acute ECOG to guide the resection margin posteriorly, and she ended up having FCD1. If you look at this red circle here, you can see microcolumns on an H&E stain, which is very typical of FCD. She has angle 1A outcome at 1 year. She took herself off meds. Didn't give me a chance, but she has a very good outcome. Now, I'll show you the second case, which is a little more tricky. So 47-year-old right-handed, I've shown this case at ACNS before. Seizure onset at the age of 26. She has no recollection of her episodes. Our sister describes her episodes as sudden onset of laughter or, screaming with shaking of her arms. So the patient is dialeptic from the get-go, so she has no aura. So if you take the laughter into account, if that is what she does, then she has a gelastic seizure. She at least starts with a gelastic. The shaking of the arms, we don't know what it is, so you can call it a bilateral unless you record one. She's obviously dialeptic from the get-go. Again, you have no lateralizing signs here, but gelastic seizures outside of the hypothalamic hamartomas almost equally distributed between frontal and temporal lobes, so you don't know what it is. It could be frontal or temporal. So this is an emotional hypermotor seizure to be classified more appropriately, right? And she is dialeptic. She does not recall. She's unresponsive during the seizure. Again, emotional hypermotor seizures, the most likely epileptogenic zone would be frontal. Temporal would be the second, probably. In frontal lobe, this is usually more localized to orbitofrontal or rostral-cingulate or frontopolar. And in temporal lobe, it could be mesial temporal, although the frontal lobe is overwhelmingly more common epileptogenic zone than this one. This is our scalp EEG. The majority of her spikes were right frontal, maximum FP2 more than AF8. She did have a small percentage of spikes all the way on the left side in the temporal lobe, FT9T7 as well, FT9F7, I'm sorry, 25% of her spikes. This is her, ictal EEG scalp. So this is the pre-ictal baseline, or 1 minute 37 seconds from the seizure. You can see this is, I want to pay attention to the RR interval here, the heart rate. That's what it is. So you have 1, 2, 3, 4, it's about 800 milliseconds. This is about 15 seconds to the hypermotor behavior. So what the first thing that happens, you kind of lose the backbone on the right side. And then the other thing that happens is that she has a tachycardia. Okay, that's actually her first sign, and we recorded this on multiple seizures. She never reported any fearful sensation or any other aura, so we thought this was actually a tachycardic seizure because it wasn't secondary to anything that we could think of. This is way before the hypermotor behavior starts. And this green line obviously is where you can tell the hypermotor behavior starts, and then obviously the EEG is quite obscured because of the significant movement, but it seems like there is some sort of bifrontal paroxysmal delta with this EEG, even though it's quite obscured. So we did an ictal SPECT as well. The injection occurred 8 seconds from EEG seizure onset, but 19 seconds from the tachycardia onset, as I measured it afterward. And we saw hyperperfusion in the right insula. Okay, right there, you can see that picture right there. And her imaging, she had atrophy of the right hippocampus. And on the FDG PET, she had hypometabolism of the right temporal lobe and a little bit in the right orbitofrontal lobe as well. So this is a case where you have quite a bit of discordance between different pieces, not quite a bit, but significant discordance. So your epileptic lesion or the lesion zone, we don't know if that's related to epilepsy, is in the right hippocampus. Your irritative zone is right frontal and left temporal. Your seizure onset zone is defined by scalp, which may not be the onset, it is bifrontal. By ictal SPECT is right insula. So it seems like most things point towards the right hemisphere, at least. Majority of the interictal spikes are right. There's significant abnormalities. The ictal SPECT uptake is on the right. So at least we think it's primarily in the right side. Now, whether it's temporal, insular, or frontal, we don't know. So we have a problem, right? And the symptomatogenic zone of hypermotor behavior is not very well defined either, just like automatisms. But some people claim that it is the mesial frontal lobe or the cingulate. But again, same problems, having to reproduce it with cortical stimulation without producing after discharge or seizures. So this is your distribution of various zones in this particular case. So this is a case where you can solve it. You hope to solve it by phase 2. This is an ideal case to do phase 2. So our phase 1 hypothesis, but very, very important, you should not go into phase 2 without a hypothesis. You must have a hypothesis. So our hypothesis, when we looked at this case, we reclassified as tachycardic to emotional hypermotor seizure. We have no lateralizing signs. We thought this was right orbitofrontal epilepsy because the majority of the spikes are right frontal. The seizure is late, so we have it's not an onset, but what we have is what we have. We thought it was right orbitofrontal epilepsy, and we thought the right hippocampal atrophy is a related medical condition. Okay? But, there's quite a bit of discordance, so we did a phase 2. We implanted 2 electrodes orthogonal into the hippocampus, 2 or 3 in the insula. mainly in the anterior insula, and several orthogonal into the frontal lobe, covering orbitofrontal, cingulate, and other mesial frontal lobe, including the superior frontal gyrus and the middle cingulate. So when we recorded her interictal, she did have a continuous focal slowing in the right frontal region, which was this area highlighted at the electrodes there. She did have spikes, most frequently in the right hippocampus, as you guys can see here. Very clear repetitive spikes in the hippocampus, which were maximum in the context inside the hippocampus, of course, and then disappeared outside, as shown here. She also had high frequency oscillations superimposed on the spikes. She did have spikes in the right frontal lobe, like this complex one, which was only 20%, interestingly enough. So the most frequent spikes were inside the hippocampus. Her seizure was the one that surprised us the most. The seizure started with the same repetitive spikes in the hippocampus, then was replaced by this kind of paroxysmal spike rhythm inside the hippocampus. So the onset was inside the hippocampus. And then about 19 seconds later, it started to invade anterior insula. And that's when she developed the tachycardia. So 14, 15 seconds later, she developed tachycardia. By that time, the seizure invaded the insula. And then quite late, it invaded the frontal lobe, the mesial frontal, the orbitofrontal. And that's when she developed hypermotor behavior. So the seizure was starting inside the hippocampus, we were quite surprised by that. And then you can see here towards the end, you have this rhythmical activity in the frontal lobe, but this set of repetitive spike with high frequency activity continues in the hippocampus. Like it looks like, lateral, like periodic discharges as the seizure is ending. So in this case, what the SEEG helped us was that it actually said the seizure onset zone is actually inside the hippocampus, which is where your lesion was as well, the atrophy was, and part of the functional deficit zone. So we were able to get concordance between the lesion zone, the irritative zone, and the seizure onset zone as defined by intracranial EEG in this case. So this patient actually underwent standard anterior temporal lobectomy on the right side, and her pathology showed chronic gliosis. And as far as I know, she's still angle 1 at 1 year. I think she's on meds. She's in Kuwait. She has to come back for an evaluation. But this is the best I know. So she's doing well, considering how frequent her seizures were. So is this, or do we have like a network of zones, or is it like a zone of different networks? What is it? I don't really think that these two people were saying different things. I think they're referring to the same thing, and they're just putting it in different words. I think the network theory sometimes gets overused without actually understanding what it is supposed to mean. But you have to remember one thing: the definition of epileptogenic zone defined by SEEG was not initially developed to guide surgery. The SEEG was invented to study semiology. It was not defined. So it is very important to have a robust phase 1 hypothesis before you go to phase 2, if you have to. So what are some of the differences? So the Luder's epileptogenic zone is primarily a surgical anatomical definition. Van Coe's is an SEG-based definition. Luder's epileptogenic zone, there is no direct biomarker. Van Coe's epileptogenic zone can only be defined by SEG, primarily. Luder's epileptogenic zone is confirmed by post-op outcome. In Van Coe's definition, you can define it very well preoperatively by using SEG, by using all those, the seizure onset and defining the early organization. And in the Luder's concept, what we do is we do our best to approximate the epileptogenic zone by defining everything else very carefully. In the Van Coe's definition, you define the seizure onset zone and you define the spread zone. That's where there's a little bit of debate is what exactly is this early spread or the organization, which is there's a little bit of difficulty understanding that. The Luder's epileptogenic zone cannot be defined fully preoperatively because there's no biomarker for the potential seizure onset zone. In the French definition, there are no other zones. I mean, there's a propagation zone, but that's pretty much it. The seizure semiology of the seizure are defined by the symptomatogenic zones. And the Van Coe, I think they're saying the same thing. They just use the word network, but there are some fundamental differences there as well, which are important. The Luder's definition is pragmatic, it's holistic, and it's a dynamic concept. Some people think it's static and two-dimensional. I don't know how they got that. There's no reason, just because most work was done using ECOG, that does not mean that we think of the epileptogenic zone as a two-dimensional concept. That's not true. And Van Coe epileptogenic zone is strict EEG based, and it's defined static in time. So you don't think about the future. There's no potential seizure onset zone there. Similarities, both agree that the epileptogenic zone is essential to initiate seizures. Both agree that the semiology is very important. In fact, The French developed SEEG only to study semiology initially. And they both agree that the expression of ictal semiology is explained by where the seizure starts and how it spreads in the brain. And both also agree that the seizure onset zone is not equal to the epileptogenic zone, which is very important and a fatal error if you make that in doing handling cases. However, the most important message is for fellows and residents or students, intracranial EEG implantation, whether you implant grid or SEG or both, it must be guided by a robust phase one hypothesis. Never implant a patient without a phase one hypothesis, because then you don't know what you're looking for. Okay, as I showed you before, phase two cannot solve the problem of a poorly done phase one. You have to have a good phase one. You may not need a phase two, but you may need it to answer some questions. But if you have a poorly done phase one analysis and you have no idea where you're looking for, where the epilepsy is, and then you just implant electrodes, you're not going to solve the problem. You're going to make it worse. Okay. This is a very interesting study that was published in the Green Journal a couple of years back. It was a survey of accredited epilepsy centers in the United States between 2012 and 2019. So if you look at the numbers here, the total procedure volume for intracranial monitoring has increased from 1746 to 2,309. So there's a 32% increase in intracranial EEGs. This is as of, published in 2022, so data up to 2019. This is probably even more now. Temporal lobectomies went from 1424 to 1508, so only a 5.9% increase. So you can see the discrepancy there. Extratemporal resections went from 784 to 877, so only 11.9% increase. Intracranial electrodes without resection went from 406 in 2012 to 1,022 in 2019, so 151% increase in intracranial EEG recording without doing a resective surgery. Median temporal lobectomies in level 4 centers decreased from 9 to 6 actually, whereas median intracranial electrodes without resection increased from 2 to 4.4. So we're doing more intracranial EEG, we're doing less surgeries, we're doing less resections, okay? Now that is not necessarily a bad thing. That could be because SEG implantation is less invasive compared to grids. When we were doing mainly grids, when you do a grid, you have to do a craniotomy. So in most cases, we are already relatively confident that we are going to offer some sort of resection. You don't want to subject the patient to craniotomy and then say, sorry, we can't do anything. With SEG, I think people feel more, it's less invasive, so we do implant more, but we do less surgery and with the increase in neuromodulation. But the other reason is we're not doing a good job at phase one. Okay, that's the other thing. So it's very important that centers in the US, we need to work harder on our phase one evaluations. The phase one evaluation has to be very meticulous and precise, because otherwise you're implanting and you're coming up with nothing, which is why many of these cases don't end up going to resective surgery. It's a nice quote from Vineet wrote a nice paper. He's an epileptologist at Cleveland Clinic. He wrote this nice paper. It's like an editorial published in 2024. It's a straight quote from the paper. It says, a die of SEG's success is cast during the pre-implant hypothesis generation, which guides the cortical sampling. Trainees, this is aimed at you guys, the fellows, should especially heed this fundamental fact, because the analysis of SEG is intellectually enticing and stimulating. It can potentially pull their focus and energy away from learning the fundamentals of scalp electroclinical correlations and synthesis of robust, hierarchical, and testable pre-implantation hypotheses. There is no substitute for the latter, especially once the Rubicon of SEG implantation is crossed. It's very important, very poignant, and which is why when you are going to implant a patient, you better have a hypothesis, at least two contrasting hypotheses that you're trying to test, this versus this. That's the point. When we interview fellows, and a lot of them ask us, how many SEGs do you do, or how many this and that? It's all important, of course. The volume is important. What is more important is how much time do you spend on a good phase one? How robust is your presentation? How much time and energy are you spending in presenting that data in a meticulous fashion? As you guys know, how we do, we spend a lot of time with you guys here when we're presenting that. That is important, because once you have decided to implant the patient, after that, you cannot go back. You have already implanted the patient. So if you get no data or barely helpful data, it's done. So it's good to have. It's very important to have that hypothesis done first. So our philosophy here is we strongly emphasize a meticulous phase one planning for our patients. We follow the Lunar's concept because we believe that it is very pragmatic, it is very well defined, it's very practical, and it's very dynamic. It's very futuristic. we always, when we think about it, we're not thinking with the patient in that time. We always think what's going to happen later. Is the patient going to continue to have seizures? And there are several things that play a role in that. We carefully analyze and compile the data and present it systematically to a multidisciplinary group. That's how it should be. And we follow a patient-centric approach. And if seizure freedom is a top priority, we strongly prefer to do resective surgery with or without phase one, if feasible. Okay. Anybody seen Pursuit of Happiness? One of my favorite movies. It's a beautiful quote. And it's read, "It was right when then that I started thinking about Thomas Jefferson with the Declaration of Independence and the part about our right to life, liberty, and the pursuit of happiness. And I remember thinking, how did he know to put pursuit in there? That maybe happiness is something we can only pursue, and maybe we can actually never have it, no matter what. How did he know that? So you replace Thomas Jefferson with Hans Luther's, and you replace happiness with epileptogenic zone. Maybe we can never have it. Okay, but you can do your best to define it, so you can pursue it. You may not have it, but you pursue it. Okay, that's my advice to you guys. So thank you so much. This is an old picture from my fellow class. Be happy to take any questions. Anybody have any questions? No? Crystal clear. Okay, very good. The next one is not next week, because next week is the SEG conference. So we're going to skip next Monday. We're going to start again on